and want to hand it over to you. So we do record the didactic session. We stop the recording after the didactic and we share the recordings with everybody so they can learn from the didactic later on. So just letting everybody know as well. So I'll pass it over to you.
Thank you so much, Catherine, for that warm introduction and the invitation by you and your team to give this didactic. It's so nice to see Asita and many other faces I know going back years. So thanks to everybody for joining. So let me just see if I can put this into presenter mode and get us going. Can you guys see the slides? Yeah, I'm seeing you
Yes.
nodding. I don't have any relevant financial disclosures. My task today was to talk about screening and treatment, which is a fairly large topic. So I'm going to try to move quickly through these slides because I really do want to have time for questions and also for the case presentation. Here in the United States, screening has been updated as of March 2023 to really be recommended by CDC and others to be done for all adults greater than 18 years of age or older. And this is one-time testing for all adults, but it doesn't replace what we were already recommending, for other groups. And other groups certainly include with each pregnancy, right, that we screen for hepatitis B. It's nice to see so many different folks from public health and also from perinatal programs joining us today. And then in these patient populations that might have kind of ongoing risks, such as injection drug use, justice involvement, there may be opportunities certainly for recommended periodic or ongoing testing for some of these groups as well. So just to really cover again who we recommend for screening in the United States. And I do also acknowledge we have an international audience here today, so I'd focus these slides really for kind of what we're doing in the context of the US. So there might be some differences or nuances depending on where you're located. But hepatitis B testing is now recommended also not just to be done for all adults at least one time, and in those with ongoing risk in periodic settings, but to also be doing testing using the triple panel test. So this includes 3 tests: hepatitis B surface antigen, hepatitis B surface antibody, and then the total anti-HB core antibody as well. So step 1, whenever you're thinking about screening, is to check these 3 markers. The one thing to keep in mind is that if you suspect acute infection where somebody is coming with a viral prodrome, jaundice, has had a recent exposure, then you also want to make sure you're checking or screening with the core IgM antibody, which gets produced very early on in infection as a marker. But this is kind of just like what the 3 tests are. And really the thing to keep in mind here is that the hepatitis B surface antigen is really your marker for active infection. Once you develop surface antibody, that's typically a marker of immunity, and immunity can be either from having been exposed to the virus itself before or through vaccination. And then presence of the core antibody total is how we tell if, for most patients, if you've had prior actual exposure to hepatitis B in the past. Now, once the surface antigen is positive, we do additional tests, and the additional tests then help inform kind of treatment in part. So what are these additional serological tests? The serological tests include a hepatitis B E antigen, which again can be a surrogate marker of a high viral load or earlier kind of period of having chronic infection. And then E antibody. So you typically lose E antigen and then go on to develop E antibody. That's an antibody to the E antigen. And that's typically associated with a lower viral load. And then the other kind of key piece of testing when we're doing screening when somebody is surface antigen positive, so they have the marker for active infection, is really checking to see if you can detect virus in the blood. And the presence of hepatitis B DNA PCR is typically how we do that. Then that's a marker for active viral replication. So these are the interpretations that you see at the CDC website and other places, and how to interpret the triple panel screening, the first step for screening, right? So again, if that surface antigen is positive, somebody has active infection. In order to be calling them a person with chronic infection, you have to have the presence of surface antigen for 6 months or longer. And it's really important in both of those patients with active infection or chronic infection. So if somebody has surface antigen that's positive, link them to hepatitis B care so that they can be evaluated to see if they do meet chronic infection versus acute, in which case you might monitor them for a period longer to see if they clear or not. And if they have chronic infection, then to think about assessing them for where they are in terms of their hepatitis infection and impact on liver disease to inform then who needs treatment. Once somebody loses surface antigen and has been infected and exposed, they should usually then go on to develop core antibody as well as surface antibody, and that's an indication of resolved infection. So you want to definitely counsel these patients for reactivation risk in the setting of immunosuppression or immunomodulation therapies. And then in patients who are only surface antibody positive and the surface antigen and the core antibody are negative, that indicates somebody typically who's been immune to is immune to hepatitis B from prior vaccination. And the key kind of language has actually shifted on the CDC website, to really ask about if they finished a completed series. And if they haven't, you can have antibody from vaccines without completing the series. And we want patients to complete the series. So, and if not vaccinated, then to complete the complete vaccine series. And then finally, the last two scenarios include all three tests being negative. So I'm going to skip to that bottom row there. And that's somebody who's susceptible, never infected. And those are patients we want to be offering Hep B vaccines to, definitely for all adults. And then above the age of 65, still considering offering it to your patients, but thinking about, risk as part of the discussion. And then the second to last row there is somebody who's only core antibody positive. And this is always the most confusing interpretation of the test because there is more than one interpretation here. For 9 out of 10 or more patients who have just core antibody positive, it will be a marker for resolved infection where the surface antibody levels have waned over time. And so in those patients, you want to counsel about Hep B infection reactivation risk. And then occult infection is the 1 out of 10 or less than 1 out of 10 really chance of interpretation there. And that really is defined and outside of the scope of what I'm going to cover today, but somebody who actually has the presence of virus either in blood at typically very low levels. So if you check their Hep B DNA, so in all patients who are just core antibody positive, we typically check their Hep B DNA, but some patients won't have it in the blood and we'll only see it on things like a liver biopsy. We don't recommend a liver biopsy or going to do those extensive measures outside of checking the Hep B DNA typically for most of those patients. And occult infection does look like it's more common in certain parts of the world, especially where there might be mutations to the S component of the surface antigen. And in those patients who have detectable DNA who are core positive, you want to link those patients to care. Okay, so that's the most confusing interpretation, but one to be aware of. So when to refer to a specialist, all people who are hepatitis B surface antigen positive need to be evaluated and managed, and possibly treated for Hep B. So, and the referral to a specialist here, I would say, is really based on a primary care PCP comfort level. We have a lot of primary care providers in the United States, as well as internationally, globally, that do have a comfort level around not just screening, but then evaluating and treating patients for hepatitis B. So I think the real take home there is that surface antigen positive need to be evaluated and managed for their hepatitis B. Hep B treatment should be considered in certain categories of patients. So this immune active category where they are e antigen negative or e antigen positive to decrease the risk. And I'll show you kind of the graph that we often refer to. And then patients who are not on treatment should be monitored regularly with blood work every 3 to 6 months. And in patients who have very advanced liver disease, who meet criteria for liver cancer or cirrhosis, or even without cirrhosis, but meet age criteria, liver cancer screening with ultrasound every 6 months if they meet that criteria. There's been lots of discussion in our field, not just locally, but globally, about the need to decentralize care if we are to achieve hepatitis B elimination. So how do we get to simplified versions of our guidelines? And I'm going to go over what the AASLD guidelines include, but I want to also kind of have you bookmark that there are some other guidances and also other guidances outside of the United States that have already made a lot of progress in simplifying their guidelines. So you should look at kind of the local guidelines here to try to inform what's the best approach. But in a simplified approach, it would be to just really figure out, do you have cirrhosis or not? Do you have any Hep B that's detectable? And all your patients with cirrhosis, treat them, right? And if you don't have cirrhosis, then use a viral load of 2,000 as kind of your cut point to see if then you look at the ALT, if that's elevated, treat. If it's normal, monitor. And if it's less than that, again, look at that ALT to try to help figure out how frequently you need to monitor your patients and then consider treatment. Now, the goals of treatment with hepatitis B are overall to improve survival and quality of life, prevent disease progression and liver cancer, that's hepatocellular carcinoma or HCC, prevent mother-to-child transmission, prevent hepatitis B reactivation, prevent and treat hepatitis B-associated extrahepatic manifestations, which we still see, and long-term suppression of Hep B DNA and normalization of ALT, and ultimately induction of E antigen loss, or what we call seroconversion. So you go from being E antigen positive to E antibody positive. And then obviously the best but least possible outcome, but we still see it with treatment, is to induce hepatitis B surface antigen loss. And that's where really some of the newer kind of trials and stuff are focused, which I won't cover for the sake of time today. So when we think about lab tests, again, screening, those the three markers, the triple panel screening, and then if you have chronic hepatitis B infection, so surface antigen that's been around for 6 months or longer, you want to then do the additional hepatitis B specific tests that I just mentioned, including E antigen, E antibody, and the Hep B viral load. But then you also want to look at other parameters of liver tests. So very important to get an ALT or a hepatic panel if possible, and then tests that could help you understand what the fibrosis staging can look like. And we now have non-invasive methods to try to measure fibrosis. So things like APRI, FIB4, some settings, although I understand like not in all settings. We have additional kind of imaging modalities to get at a liver stiffness or scarring through elastography. So things like vibration controlled transient elastography, MR elastography, ultrasound guided elastography, and then also some proprietary biomarkers, including tests like ELF4, ELF, and FibroTest. And then liver biopsy, obviously, in select cases. But like when I was training, actually, liver biopsy was what we had to hang our hat on. And it was always a judgment call in terms of figuring out the best timing of when to consider a biopsy, because you don't want to have to do that a lot of times for a patient if you can avoid it, obviously. So I talked a little bit about certainly treatment at this current point in time is not recommended for everybody, right? And so we want to think about where we think a patient might be in the life cycle of their chronic Hep B infection. And I admit that this graph can be very confusing for people to look at and then try to actually make sense. But I want to just draw your attention to kind of the key components, right? So the presence at the top there of E antigen, right? The left two columns are in patients who are E antigen positive. And on the right, you see once you clear E antigen, you become E antigen negative. And then there's certain kind of places that we try to guess like where a patient might be. In the earliest kind of phase there is what we used to call immune tolerant, right? So like patients who have very high Hep B DNA levels, but like normal ALT. We tend to see this in a lot of our younger patients, particularly those who might have gotten this through mother to child transmission, depending on where you're located. But you can see as then in those patients, as the DNA level drops, you can also see ALT levels go up, and that's considered to be a more active phase, high replication, high transition point for people to start developing additional fibrosis. And those are patients who meet criteria for treatment. And then in E antigen negative patients, right, patients who have like this low virus level and a normal ALT, again, are not recommended for treatment in that period. But then if you catch them as you're monitoring kind of their parameters, including their ALT and DNA, if you see that goes up, but it can also cycle up and down, and the ALT go up, then they go back into a category where they meet recommendations for treatment. And the key here is like once you start treatment, it's not to like stop and start. You like start treatment, and right now with the therapies that we have approved, it's then committing patients to lifelong therapy. And again, the goal is to keep the virus suppressed, but also to see if you do get lucky and have some of these additional benchmarks that happen, including surface antigen loss, which is not common, but would be an indicator that the infection has resolved. So who should be treated? And again, current American Association for the Study of Liver Diseases guidelines recommend that the decision should be based on the Hep B DNA level, the ALT, the stage of the liver disease, and risks of complications. There are some categories that fall into a must treat, right? So anybody with cirrhosis at any Hep B DNA level is recommended for treatment because we know that outcomes are improved in these patients, including decreased chance for decompensation, as well as a decreased risk for liver cancer. Patients with Hep B DNA that are above 20,000 who are in that E antigen range, depending on the ALT and fibrosis assessment. And then those with the DNA level above 2,000 who are E antigen negative, depending on the ALT and fibrosis assessment. I think some large things just to kind of broadly keep in mind is to consider treating, and this is how I really practically think about it, because these little specific things can be really confusing and difficult, is like if anybody has signs that they have, stage kind of F2 or middle of the ground fibrosis or higher, that's somebody who's already showing you in their lifetime that they are developing significant fibrosis, and those are people you want to consider treating. Patients who have a family history of liver cancer or extrahepatic manifestations, and then patients who might be immune tolerant who are above age 30 is another category. So really thinking about how can you simplify this so that you can apply it in a clinical scenario, I think are really important. So lots of discussion in our field about why not to treat everybody or why to treat everybody. And there's pros and cons of this. And I do think it's important to acknowledge because it's certainly been a focal point of lots of discussion as a field. The pros are that current guidelines for treatment are complex. We know that treatment rates, which I didn't show in these slides today, are woefully show under treatment and really have left behind too many people undiagnosed or improperly managed. Which is obviously a huge disservice to patients, right? And treatment significantly, we know, improves outcomes, right? It reduces your chance of developing liver-related complications, including cirrhosis, decompensated cirrhosis, and most notably, liver cancer. And then finally, the current guidelines, as I just showed you, are kind of difficult, and I'm going to go into a little bit more details of what I showed you. But it's difficult to implement in real-world settings. Getting patients to come back every 3 to 6 months to get blood tests done, having somebody who has the training and the knowledge to interpret those tests to know when to treat. And then the cons there certainly are it's theoretical, but maybe not practical, right? And not everybody will develop significant fibrosis, but we don't really have the tools at this stage to say at the age of 20, you're not going to run into trouble in your lifetime. And then limitations of current treatments, which really necessitate the need for long-term treatment. The cost stuff has been shown, I think, kind of both ways. And then some implications for drug resistance, although we don't really see that with first-line therapy. So I think that's really more of a theoretical kind of concern. So I think things to think about. I think our field is still figuring out how do we do a better job of simplifying treatment. And you'll see people kind of in both spaces talking about what's in the guidelines and what the discussion that we're really having is and how do we get patients served in the way that they need to be served. So certainly, again, in the AASLD guidelines, which is what I'm showing you here. Oops, I think I skipped. So if you're E antigen positive, and again, the threshold for upper limit of normal for an ALT test that's normal in men is 35 and in women it's 25. So if you have if you're E antigen positive, and you have a DNA that's above, 20,000, and your ALT is below the upper limit of normal, they fall into the do not treat monitor. So match the last box. So HBV DNA is in light blue to the recommendations down at the bottom. Patients who have an ALT that's above the upper limit of normal, but below 2 times the upper limit of normal, but have a DNA who are above 20,000, you want to exclude other reasons for why they might have liver disease, including alcohol, right? Hepatitis C. A lot of patients have metabolic factors globally across the world. And then you want to think about really staging, right? Does this patient have stage 2 fibrosis or higher? And if they do, then consider that patient for treatment, right? And if they don't, then you're in a zone where you can kind of monitor them for a period of time more intensely and then move it out to every 6 months. And then if the ALT is above 2 times the upper limit of normal, their Hep B DNA is high, then these patients meet above 20,000 treat. There are these weird gray zones, though, again, you see for patients who have a viral load between 20,000 and 20,000 IUs per liter. And this might be those patients who are in an active phase of seroconversion, like losing e antigen. So you want to monitor them like every 1 to 3 months, and if that persists for greater than 6 months, and then consider treating. So again, these gray zones is where like lots of confusion lie for providers in trying to figure out a very simplified way also to really think about that. Anybody who's got a fibrosis test that's showing you that they have, it's a good quality fibrosis test too, okay, because there is some variation in non-invasive tests. But if you see significant scarring, stage 2 or higher, and the scaling of scarring goes from 0 to 4, so middle of that ground scarring or higher, you want to treat all of those patients. And then in e antigen negative patients, the criteria are a little bit different, but again, you see these gray kind of middle zone kind of patients of needing to monitor them, and that's not easy to do. I think we all acknowledge that. But if the ALT is low and their Hep B DNA is less than 2,000 IUs per ml, do not treat those patients, but continue to monitor them every 3 to 6 months. And then if they're in this gray zone, again, where the ALT is very low, the DNA is 2,000 IUs or per liter or higher, then think about more kind of active monitoring and fibrosis assessment to figure out. And then you again have this middle group of ALT above the upper limit of normal, but below 2 times the upper limit of normal. And if their Hep B DNA, again, is either really any, I don't even know why we have this separated into 2 boxes because they all both fall into the gray there. Again, exclude other liver diseases, fibrosis, assess them, and then think about whether or not they meet criteria for treatment. And then if their ALT is above, greater than or equal to 2 times the upper limit of normal, again, using those ALT thresholds, the DNA is above 2,000 or higher, then to treat those patients. And if it's less than 2,000, you can be monitoring them, fibrosis, assessing them, and then sorting out whether or not and when to do treatment. So I do want to acknowledge that because of all the discussion in our, sorry, not intended. Let me go back to my slides.
Oh, no, it's coming through still. You're good.
Oh, okay. Okay, let's just see if when I advance, it keeps going. Okay, so this is like a proposed simplified approach that we've seen a lot of. Can you still see? Yeah, okay. I don't know why it's just, maybe it's where my mouse is. Okay. So this is like what a consensus of experts have recommended as a more simplified way of also trying to get more people out of this gray zone, but really using age in the scenario, right? So 30 years and above, right? DNA level of above 2,000, then simplified and just treat all of those patients. But in those patients who are under the age of 30 and have a Hep B DNA that is above 2,000 and an ALT that's elevated, again, think about treating those patients. So I think I left the e antigen part of the slide, so I can redo this and send it to you guys. But I think this is all to say that like we are still really discussing about how do we get to a place where we can simplify this. And like I said, I think actually globally, we're seeing lots of countries take some important steps around simplifying. So I would say look at your local context of where you're practicing. And you'll see that the guidelines are not all aligned right now in terms of some countries really taking great bold steps forward to simplify. Okay, and then to kind of get into monitoring. So again, for patients not treated, think about monitoring them essentially every 6 months. If you had to like take one thing away, labs every 6 months will help inform kind of where you are with things. The range is 3 to 6 months, which is also kind of confusing for some of our patients and our providers. And then you can, again, have these slides to refer back to, but thinking about your e antigen positive patients, e antigen negative patients, and then looking at the DNA thresholds or age criteria. So I wanted to spend a little time on medications. And, certainly we have a number of nucleotide analogs, and then we have immune modulatory or antiviral therapies. Those are the main classes. The ones highlighted in green are what we consider first-line therapy options from guidance, and also like some of the brand names on the right there. And so among these first-line treatments, you'll see different routes of administration. So interferon notably is subcutaneous. by week for 48 weeks, which is certainly a significant period of time, but it is the one finite treatment option. The vast majority of patients will get oral treatments, which are listed above that. And first-line oral treatments are considered entecavir, tenofovir, and now tenofovir alafenamide, which all have like a daily dosing. You have the time at when they were approved. And then we have second-line treatments and we have third-line treatments, which at different points in time were kind of, before we had some of these newer treatments, considered a top-line therapy. I think the one thing about resistance really to know is that it's very, very, very low and unusual with our first-line therapies. We do see more resistance with our second and third line therapies, which is why they're second and third line now. So just a few points here. These are if you were to send somebody for resistance testing on their hepatitis B, here's just like a nice chart about what the interpretation of some of the resistance testing could look like and what patterns of resistance you might see that point to if they're resistant to a specific treatment. So lamivudine, tolbuvudine, entecavir, defivir, and tenofovir and TAF. And you can see again less red in the entecavir, tenofovir, and TAF kind of categories, which are the first-line oral therapies. And then in patients where you do see resistance, there are recommendations about switching if you have resistance to one to like one of the older third-line medications, lamivudine, switching them to tenofovir or TAF. And again, based on those resistance panels where you then see no resistance with the switch therapy. So again, just a table summarizing some of the complexity there. So again, some things to think about when you're thinking about weighing finite interferon therapy versus nucleoside or nucleotide analogs. Again, oral administration for the nucleotides and sides, well tolerated. Once you start, you typically continue lifelong for most patients. There is very small, levels of resistance, particularly with first line. Duration, for most people, it's going to be lifelong. I'll talk about stopping rules. And then, long-term safety with some of these newer medications is always listed as one of the possible things to consider. And then with pegylated interferon, it's finite duration, sustained response, no obvious resistance. You're doing it for 48 weeks. And then some cons is you have to inject it. A lot of patients don't like to inject medications. Side effects of interferon are certainly there. Site reaction side effects can happen. And then not to be used in patients with advanced liver disease post-transplant and pregnancy. So again, in those patients who are then you select them for therapy and then you talk through a therapy option, what is the monitoring plan? The monitoring plan typically involves following the ALT and serum Hep B DNA levels. You want to do kidney monitoring, particularly in patients treated with tenofovir. And for long-term surveillance, right, for patients who meet criteria for liver cancer screening, it's recommended that all patients who meet criteria for liver cancer risk that they get, ultrasounds with alpha-fetoprotein, and then for all patients, even if they're DNA suppressed, you keep monitoring them. I'm going to actually skip over this slide just because I don't want the slide component to go too long. But again, this just talks about kind of different therapies and seroconversion rates. And you'll see that with the interferon therapies, you have a little bit higher seroconversion rates. But again, finite therapy injection, 48 weeks versus oral therapy, which has much lower, e-antigen seroconversion is not that bad, but if you think about surface antigen loss, right, it's higher with the interferon therapies than with the oral therapies. Okay, and then some just nuances. So like, would you pick between a first-line therapy? I think shared decision-making is always helpful. Also figuring out what's available to your patients is really important. So some indications that have been put out there by EASL and others include like thinking about selecting entecavir or TAF over tenofovir. So age, bone disease, and renal disease are all higher with, tenofovir, particularly when you have somebody who's over 60, you might already have osteopenia or already have some chronic kidney disease. So thinking about those factors when you're trying to select therapy and first-line options. And then when to stop therapy also comes up. So Most people are going to be on indefinite therapy. Once you start, and I usually counsel everybody they start on treatment, I'm going to expect you to probably stay on therapy lifelong. When can you discontinue? After somebody has confirmed surface antigen loss, right? But you also plus minus want to see that surface antibody happen. And then you want to monitor those patients to make sure that they have no seroreversion that happens. And then in patients who are e antigen positive without cirrhosis, who achieve a stable e antigen seroconversion or undetectable Hep B DNA. And then in select e antigen negative patients without cirrhosis, and I'm not going to get into consolidation and then when to stop, but there are these stopping rules. But in general, most people you start, you're going to be on treatment lifelong. Some things to think about are counseling patients, again, who are either on treatment with viral control or treatment naive after the viral factors, is to think about other risks, right? So now we have lots of metabolic factors in our patients with chronic Hep B. So patients are overweight, they have diabetes, hyperlipidemia, things that will meet criteria for, other risk factors. So whenever I see fat in the liver and somebody who's got chronic Hep B, I ask them about alcohol and I ask them about metabolic factors and make sure I'm addressing also those risks. Okay, and I think those were most of my slides. I hope I leave enough time. Oh, so there was one summary slide I'm happy to just show to folks here if that's helpful and open it up to questions.
Sounds good.
It's like ended on me without me. Let's see if that works. Can you guys see this?
I think yes.
Okay, so it's just like kind of a general management, trying to like pull it all together and when to think about treatment. So again, happy to share the slides with you guys and have you guys reference it. But just surface antigen positive, you want to evaluate them for active infection. If chronic infection, evaluate them further to figure out if you're going to start antivirals now or just monitor them and see if they need it in the future, and then considering other risk.
Great. Thank you. That was really helpful and a great summary of hepatitis B management. So we have a lot of really great questions in the chat. I had two quick questions
Yeah.
just for clarification, because I think we hear a lot about, surface antigen loss and stuff like that. Can you tell us how frequently that happens to the best of your knowledge of seroconversion after NAs?
It's like 1 to 3% at best.
Oh,
So like
perfect.
I try to like not hang I try to set expectations for patients. So I say it's like something we could see. It's not likely that we're going to see it. You could be lucky, and I would love for you to be lucky and be in that like up to like 3% chance, but it's fairly low. And that's over like a time of being on therapy. So we do check that like once a year. While we're just checking every 6 months the rest of the tests. So that's a good question.
Thank you. And then the other question I had too, because I haven't seen PEG used all that much, though I do know it's included in a lot of treatments that are in development for clinical trials now. So I think we'll probably start seeing it more. But in your practice, how often are you seeing that for used as the treatment choice for hepatitis B?
In the US, in my settings, I'd say never.
Okay.
Most of my patients, even if we talk about it, they don't want to do injection-based treatment. The side effects are very different than interferon treatment for Hep C, and some factors are proposed as to why. So in general, patients tend to tolerate it actually a lot better than our Hep C patients. So like all of that flu-like, and because we were running trials actually at Mount Sinai and other places when I was there, that were looking at interferon based treatment, and patients tolerate it a lot better. But and maybe things are shifting now also because like Ozempic and all these other subcutaneous treatments that are, people are jumping on the bandwagon to get. But I would say, I still think the mainstay of therapy in a lot of practices in the US tend to be the oral therapies. Yeah.
Thank you. And also wanted to just highlight too, I know the ASLD is coming out with new guidelines and we're expecting them honestly any day now. So we'll be sure to update everybody as well because the recommendations could look different in a couple of months potentially. And there will be open comment period So all of you can provide feedback on to what you think the guidelines are and respond to those. So just calling that out as well, because that's important and coming down the pipeline too. I don't know if you had anything to add about the guideline updates or anything.
No, I'm curious to see like what comes out. I think like as a field, we've had lots of discussion now going on for years on this issue, and things are still very complicated. We do lots of complicated things all the time, particularly in primary care. I think that's a point that's always stuck with me from some of Sue Wang's talks, right? Diabetes management has become a lot more complicated than it was like 20 years ago. But I think we to service patients, like I think the thing, hopefully you guys show it somewhere else, but the amount of patients who are treated who meet criteria for treatment is still so low. And we miss cancers and we miss opportunities all the time. And a lot of it hinges on, getting people into care, staying in care, but then also then like our timing for treatment. And it feels very unfair. I think we've heard from lots of patients on this. So I'm curious to see what we see in the guidelines that are updated.
Definitely. We had a few questions come through in the chat. One is triple panel a standard care for prenatal screening now in the United States, or are we still just doing surface antigen only to start with?
It's
And that
recommended
could,
yeah, go ahead.
no, I was just going to say we'll also touch on this in the May session in detail. So, but go ahead. Sorry.
Recommended we still check all three because I think, again, trying to avoid like confusion about how to do screening. And the more times we make it like, well, with this one group, you only have to do this, and this group, you have to do this, it becomes harder to adopt. And the updated guidance is to do triple panel screening. But I don't know if Catherine, you have, anything else, to share on that in terms of what people are really practically doing.
Yeah, so in I think it was 2022, 2023, new recommendations came out from CDC that do recommend universal screening, and it's the triple panel for that. However, I do know that there have been some challenges with getting that approved comprehensively across the board for insurance wise. So I think there can be challenges, though. If you look at the risk factor criteria, which was used previously, most everybody could theoretically fit in some kind of risk factor potentially for hepatitis B in the US. So that's something to consider if you do have challenges with insurance. But generally, it would be recommended to screen for all because you should know if you should vaccinate or not. And also consider for perinatal prevention. There's also the risk of a cold infection, rarely, but it can happen too. So always good to check all three, I think. We had another question come through. Do you see Hep D in certain phases more? In a previous echo, it was mentioned that sometimes people have low viral load and positive Hep D.
Yeah. So I think like hepatitis delta testing. So this is it's basically like a cofactor virus. It requires the presence of hepatitis B, right, to be present in order to actually cause an infection. And so these patients have an accelerated kind of risk to cirrhosis and poorer outcomes. We tend to see more delta in some with some risks, including injection drug use and some other groups. But there has been a push, although it's not yet in the guidance. So I'm curious to see if this actually changes too, about universal testing for delta. And I think one of the historically the biggest issues has been about how to do the testing, because the testing has not always been so widely available, including the figuring out if they're low level antibody positive versus viremic, and sending the labs to centralized settings like CDC to do the testing. And I've just heard about all of the axing of the viral hepatitis lab at the CDC, which isn't going to help us, I think, with that problem. So I think these are the practical things. There are some groups, but I think the general sense is we don't screen enough for it. It's underdiagnosed. And then the viral load testing is still problematic in a lot of settings, and where you have to send it to a central agency. And now we're grappling with that lab being gone.
Yeah, that's something that we still don't quite know the challenges that will come potentially of the lab being shut down like that. Yeah, lots of work to be done, I think, too. Another really interesting question, what is the reason for all of the criteria when treating as opposed to universal treatment for all positive surface antigen patients? Are there drawbacks to universal treatment?
Yeah. So for most patients, it's not been one, it's lifelong for most patients, right? We have billions of people, right, who have hepatitis hepatitis B, right? Millions now, like, but we have a lot. And the earlier cost studies didn't show that it was cost effective to treat everybody. Not everybody with hepatitis B gets cirrhosis or any of these bad outcomes. Committing young patients to lifelong therapy has pluses or minuses, but the other side of it is a does it give peace of mind? Are patients going to take it and stay in care? You know, and I think we definitely see this more of a challenge in like the United States. When you think about who shoulders the burden of hepatitis B infection, it's a lot of our foreign-born populations, and some of them will be in and out of care because of access to insurance or just hires other additional social determinants of health. So we've kind of like made some broad decisions. I'm not saying they're all feel fair or equal or like the best. And I think that is like what we might see some movement on. So I think those are the practical things. And it was really like the cost and not everybody needing it. But then the flip is like we do such a bad job because the criteria are so complex of getting everybody treated.
Yeah, definitely. And hopefully in the near future, these simplification will continue to move forward, so we can do a better job at decentralization and also making sure that it's approachable for both the patient and the provider side, universally. Um, there were several other questions in the chat, some of which I can answer as we move through the next section quickly. Um, I think one question I think that did come through in the chat, and I also was wondering if you had suggestions on this because I think it was an important point to bring out. You had mentioned the language used to patients to share about the need for ongoing surveillance for hepatitis B, and that being a challenge, the loss to follow up potentially being a big issue there. Do you have any suggestions for how we can communicate to patients about the need for that ongoing surveillance and making sure they're educated about that?
I think the challenge for just doing this in clinical practice has been is that hepatitis B is largely asymptomatic. People don't know they have it, and when you tell them they have it, they feel fine. They're not experiencing, for most people, not experiencing symptoms. It's different when they've seen somebody with liver cancer or they've had some personal impressionable like thing, or maybe you just counsel them. I don't think we haven't figured out how to do the messaging in the best way to really say, okay, this is a chronic infection that's lifelong. I mean, these are the things I talk to patients about. You need monitoring for it lifelong. But yet we meet lots of patients who have known they've had hepatitis B and out of care for lots of different reasons, right? And then they come to us when they develop a cancer or something that causes symptoms. So I think like just really pushing on, like no matter where you go, you need to have one person, if it's either primary care or specialty doctor, that you're checking in with at least once a year, you know, ideally a couple times a year, to just check to see what your status is, because you don't maybe need treatment now, or this is where your hepatitis B is now, but I don't know where it's going to be in 5, 10, and 20 years. And everybody wants to prevent a cancer. So I do think also understanding a cancer risk around this is not to scare people, but to like make sure they really know, I don't want you to come back with a big, you know, untreatable cancer, which is how unfortunately a lot of patients then come back to care if, you know, they were in care and then they go out. But it's hard. It's challenging. These patients have, you know, higher rates of lack of insurance, change in insurance, competing priorities for things, you know, and health seeking behavior is very different in other places. So if you don't have symptoms around something, I'm not going to be bothered by it. I'm not going to think about it, you know, like that's just like a lot, like how a lot of people think of these things and health and what they need.
Awesome. Thank you. That I think we got to most of the questions. Some of them were more in depth about HIV co-infection of hepatitis B, which I hope that you'll join us for future echo sessions because we will go into more detail. I think that will take the full didactic session certainly to go into that. So I'm going to stop